doctors have had to quickly learn how to manage the treatment of COVID-19 patients. Recently, a number of clinicians published an article in the South African Medical Journal in which they outlined their experiences at the Groote Schuur Hospital in Cape Town. The hospital was once at the epicenter of the Western Cape's coronavirus outbreak. Professor Mark Mendelsohn co-authored that article, and he joins me now to discuss it a bit further. Professor Mendelsohn, good evening, and thank you so much for your time. Maybe just a bit of context in terms of what led you and your colleagues to produce this work, especially from an academic and medically recognized perspective.
We wanted to share our experiences, which have been in keeping with many of our colleagues across the country. But this has been unprecedented, an epidemic, a new infectious disease. We've learned an enormous amount from international perspective, but also from our local learnings, and we wanted to really publish our findings and how we manage patients at Groote Schuur.
Let's talk about that management of patients, because at the onset of COVID-19, there was a lot of confusion in terms of what do patients need that's going to help them feel better. Is the country going to have enough to treat all those that do contract COVID-19? So speak to me a little bit about that.
Well, people that contract the virus which causes COVID-19 will have a variety of possible symptoms and possible scenarios will play out. So a large number will be totally asymptomatic who won't need any treatment. Then there'll be people, with the vast majority, with mild symptoms who will just require symptomatic treatment for temperatures or cough. And then there are those that have severe COVID-19 and are requiring hospitalization, will require often help with oxygen support. And in those patients, the very severely ill patients with COVID, we've learned that the steroid dexamethasone or its equivalent will reduce mortality, particularly in those who are requiring ventilation, but also in those who just require oxygen, short of actually being ventilated. And we also have learned what doesn't work from well-conducted clinical trials. The main clinical trials, the recovery trial from the UK, showed us the dexamethasone benefit, but it also showed us that drugs such as hydroxychloroquine and our own antiretroviral, lecanemab, ritonavir, or Luvia, does not benefit patients who have severe COVID. So I think we've learned quite a lot, both from international and our own national perspectives.
How would you say that the strategy needed to evolve or did evolve in response to some of the challenges that you would have been facing on the ground?
Well, again, we learned a lot from international experience. We learned quite quickly that trying to prevent patients having to be mechanically ventilated was important, because very high mortality from Italy and other countries where patients had ventilation, mechanical ventilation, helped with their breathing. So we tried to use methods of oxygen support which give very high oxygen flows outside of the traditional setting of an intensive care unit. Obviously, we didn't have so many beds as they do in high-resource areas and countries. So we adapted that, and we used high-flow nasal oxygen, as did many of our fellow doctors in other parts of the country. But we used them outside of the ICU on our general wards. And we certainly saw the benefit, the patients certainly saw the benefit. That, in conjunction with the steroids, as I mentioned, and also thinning the blood, because we saw a number of patients with very severe thromboembolism, the clotting of the blood, not only in the normal areas of the veins of the leg, but also in the lung circulation. And so anticoagulation is also an important aspect of treatment.
Of course, the health system came under enormous pressure, unprecedented pressure, and that too had its toll on medical workers, individuals like yourselves that had to be on the front line. Was that part of what you've been documenting? And I'm keen to know, just the reflections of the industry being able to look at itself and to be honest about just how affected doctors have been personally by this pandemic, because it's not often you hear doctors talk about their mental health or even their emotional state of being.
Absolutely, and it's really important to say that this is not just about doctors. This is about healthcare practitioners in general, particularly our nursing colleagues, physios. Everybody was similarly, involved and affected. You can't help but be. It was a time of incredible stress, and I think what's interesting is how teams come together, how there is a camaraderie and a spirit that starts to be built within the health service, actually, which one hasn't really seen for quite a long time. So, in fact, that was one benefit. But it does take a toll. The mental health aspects of it are considerable. There are a lot of colleagues who contracted SARS-CoV-2, had COVID itself. We were very fortunate to have good backup from counsellors and from our psychiatry colleagues. And in fact, we're just hoping to publish a second paper, which actually goes into some of these issues and how we set up the response, rather than this paper, which was really focusing on the clinical management of patients.